Hello and good afternoon, everybody. I am Rebecca once again, and I will be your moderator for this session. This session is on vision and occupational therapy. And for this session, we have three presentations. Each speaker will have 15 minutes to present, and this will be followed by 5 minutes of question and answer. You may type your question by clicking on the Q&A box on the right side of your screens. Please use the Q&A box rather than the chat box for your questions to the speakers. And if you want to speak, you may also click on raise your hand on the right side of your screen. Wait for me to recognize you and to activate your microphone. Our first speaker is Dr. Sivan Regev, and she is a lecturer and a she's a lecturer. She's a doctoral. She has a doctorate, and she is in the Department of Occupational Therapy at the University of Haifa, Israel. Sivan's research topics includes the evaluation of executive function and strategy used for people with severe mental illnesses in the domains of daily living, especially grocery shopping and media use. Sivan is also an OT in a housing service for people with SMI and a professional member in the Ministry of Health committees for people who receive rehabilitation services. She is the recipient of research grants from the National Insurance Institute of Israel. Dr. Sivan, it is a pleasure to have you here today. All right. I think you are currently on mute. Can I ask you to unmute yourself? Hello,
Hi.
hello.
Hello.
There.
Thank you.
Okay. So I will be playing Dr. Sivan's presentation and we shall now begin. Thank
Great.
you.
Thank you. Hello. My name is Dr. Sivan Regev, and today I will present the presentation with both eyes open, translational research using eye tracker together with performance-based evaluation of instrumental activities of daily living amongst the people living with severe mental illness and match control group. This study is part of my PhD dissertation, and my supervisors are Professor Nami Jospan from the Occupational Therapy Department and Dr. Avi Mendelssohn from the Neurobiology Department, both from the University of Haifa. The study was supported by the National Insurance Institute of Israel, and here you can see me standing in the supermarket where we conducted the research in the beginning of COVID-19. What made us stop collecting data because the study was in a real world environment, and we couldn't continue performing it as we did before. But before we deepen in the study itself, I want to start with the theory. So, as you see in the title, it starts with translational research, and translational research acts in two ways. It translates research within the theoretical area and from theory into practice, as Wolf state. This study question was, what is the behavior and executive function of people with severe mental illnesses during a real-life task performance? In order to answer this question, we start with step one, systematic review. So you can see this article was published in Schizophrenia Research Cognition, and we asked the question of what evaluations are out there for people with severe mental illness in terms of executive function and everyday life. We took a broader concept and not just IADL because we wanted to see in other professions too. So we found 104 articles discussing this question, and it was all around the world. Here I marked Israel and also in your area, and if you look in the article, you see that we made big tables of assessments for executive function and assessments for IADL, and we found also assessment that examined both. Most of them were performance-based assessments in which you can measure a task performance, and during task performance see how people behave and learn from about their executive functions. So step 2 of this study, was the activity analysis of the assessment test of grocery shopping skills. We took this task, which was to select 10 items in an unknown supermarket and select them for their lowest price. So you see this diagram, it shows the steps within it. First, the start, when the subject stands with the list and can plan and scan the area before he starts performing. Then item detection, where the subject walk around and look for the 10 items in the supermarket, using the list, asking for help, using the signs, categorize the items, maybe the two things next to each other. So this is part 2. Part 3 is the item selection itself. We call this event in order to make it organized for us. And every event has the steps of scanning the shelf, finding the size that was in the list, find the prices and then compare them, and in the end select the item and take it and check that it was the right thing from the list. The last part was check and end, in which the subject checked that he has all 10 items and walk to the end of the store and finish the task. Here you can see one of the subject, and she's wearing the eye tracker. So after analyzing the task, we also add, for this specific study, the eye tracker. That was step 3, which help us take the move from the eye of the researcher, from the observation we do on this specific task, to the eye of the subject. And I want to show you. Let's see if it works. Okay, it doesn't work. Here you can see the list, and you can see these dots are the fixation on the list, and this is the path where this specific subject scanned the list in the beginning of performing the task in part 1. Step 4 was defining the outcome. So we do have 2 parts of outcomes: the TOGS outcomes and the eye tracker outcomes. The TOGS gives us the efficiency of performing the task, which is measured by the total time in seconds, and the redundancy. You can see here a map where we walked with the subject and we marked his path. And if someone walk several times in an aisle, we mark the redundancy. And so this is the redundancy, and the total time is for the efficiency. And the other outcome of the TOGS is the accuracy, which is measured by the correct item, correct size, and correct price of each item, and then combined together to 30 points. The eye tracker has many details and many data we could take from it. What we did, we made a 16 area of interest on a shelf in order to measure the fixation amount and fixation duration. So because we wanted to be as specific as we can, because together with the fixation, we have the light, we have the angle in which the person reached the shelf, the shelf, yes. So we wanted to be as much specific as we can. So, okay, soon when I'll show you the data, I'll explain what we did with it. The step 5 was to analyze the results. So from the part of the TOGS, the task itself, we saw that the SMI group, let's start with the control group. Control group act as was accepted. The redundancy and the time were correlated, which make the efficiency stronger, and that what we expected, that they will correlate, and also the redundancy and the time in which they looked for the items, it's expected to be matched. But in the SMI group, we see other things. We see that the detection, the walk around and look for item, match negative to accuracy, and that TOG's time for the selection matched with the fixation amount. What mean that when people stand in front of the shelf, people with severe mental illness stand in front of the shelf, they produce a lot of fixations. Soon we'll combine it all together. And the eye tracker result, we see that the result of all item selection, we chose 4 item selections, events, as I called them before. There were consistency among all the subjects, because sometimes we had to change the ingredients because of what there is in the supermarket, and sometimes it wasn't correct. But the 4 items that were consistency in all with all the subject was the spaghetti, the paprika bags, the soap, and the can of corn. So for all these event item selections task, there was a greater percentage of fixations by the SMI group when scanning written information relevant to decision making. What means that, okay, so now move to the conclusions. So I'll say it and then I'll move to the slide. What means that, as we saw here, when people stand in front of the shelf, they made the whole work, while people from the control group gather the information during walking in the supermarket. They were working all the time, and it was more efficient. And now I'll move to the conclusion that I said now. So the step 6 is conclusion and summary, that we saw that the selection process was found to be significantly more accurate and efficient for the control group than for the SMI group. I haven't shown it the data, but that what we found, and that was expected by former articles. And we saw that performance efficiency was found to be more affected by the planning and gathering of information during the entire process, rather than the direct point in the process at which it was expected. What means that a better strategy would be to make the information gathering in the whole process and not just in the point you need it. And it changed a bit my assumption about practicing and strategy use with patients, that maybe we should broaden it and use strategies even where we don't expect them to be needed. I moved to the research limitation, and I talked about it in the beginning, that intervening variables out of the lab are wide, and they were wider even more during my research because of the times we facing now. Um, but it wasn't only COVID. The next step is COVID-19, but it was also the supermarket and the things that changed. And I expected to have 10 items that I can analyze, but in the end, we chose only 4 because things are dynamic and changing in a real world environment. And also because of that, we had a small sample size of SMI group. People wasn't willing to come and do this task outside in the supermarket. It was difficult to them, so we had a small sample size for the SMI group. That why for future research, I will suggest to choose maybe tasks that are relevant and examine the things we examined, but in an area which is more controlled for the subject, maybe something inside in the work or in other places that he or she knows. That would help to gather a larger sample size. And also, I suggest that planning should be addressed as a specific executive functioning component. We saw here that it was very important, and it was very interesting to see. And I do suggest that it would be it would have more focus in future studies. Thank you for listening. I'm inviting you to look for more publications and ask me questions now about this study. Thank you.
Wow, okay. How'd you find that ding?
That was so interesting actually. I've never come across a study such as that. So it's really wonderful how technology is allowing us to expand what we can do for our clients, not just in assisting them but also in helping evaluate. So that is really something interesting that I'd like to eventually be able to apply here as well in the Philippines. And I'm sure our audience, some of them work with persons who are of the same population or who may have same concerns, would be interested in applying the same as well. Yeah.
That's exactly my thoughts, Ding, because as I was mentioning to you in the backstage, I don't think a lot of occupational therapists in the Philippines are actually so focused with visually impaired. I think with Mom Anna's group, right?
Hmm.
I
That's
guess
true.
I guess they would agree that they're more focused with that population. But I wonder how focused are you in really helping visually impaired people in Israel? Because it's something really interesting. It's new for us, even the technology that you have presented in your presentation.
So it's the evaluation is by the eye tracker, but it's not. I wasn't measuring the visual itself. I was using it to understand
Hmm.
how the mind work and how people behave with like more the executive functions was more in the
Yes.
focus, and the vision was the way to understand it. But there
Yes.
is a lot of studies about visual impairment too in occupational therapy. It's different, but there is in Israel.
That is true. That is
Yeah.
true. So it was for a population who have SMIs after
Mm-hmm.
all. Yes. I'm very curious because it's not something that I would probably have been able to think of on my own. What was the impetus for this study? How did it come about?
So we do in my university, in Haifa University, we do a lot of collaborations.
Oh.
So my two supervisors, they thought about it, and I wanted to deepen my understanding on executive function, and they said, let's take a new tool of the eye tracker and use it, and it was amazing.
Definitely, it's a very different perspective from what we would
Mhm.
usually take, and very innovative at that. That is really much appreciated, and it can expand as well our interventions because we know
Mhm.
more about what's happening. And I'm also curious about this. So you've mentioned that there is a need to address planning in the
Yeah.
executive functions, but given this behavior from clients with SMIs, are there any recommendations that you are now thinking of, given those behaviors that they exhibited? Are there any environmental modifications that, at the top of the head, would help them in the selection process in obtaining the information much easier, given their current way of doing it?
I think it like performing this evaluation. I did most of the evaluation itself,
Mm.
and I saw how stressed they were, and it was they wanted to be accurate, and they were like by the end they did the same in the accuracy, and I think we can be less stressful and say it's fine, maybe it's okay that it will cost a bit more, but that you will do it regularly every week. Because when I asked them if they do shopping, they said once a week, a month maybe, and with a friend or with a consultor. And I want them to do it like fine, like everybody else.
Oh,
And
that is awesome. Yes.
maybe less stress on the strategy of the accuracy and more of the efficiency and just doing it.
That's true. That's true. And that definitely ties in with what our previous keynote speakers were talking about, being more client
Mhm.
centered. So that is
Yes.
really a wonderful thing that you have done. And we are very grateful to have been able to hear about the results from your study. And this is something that we can also apply in local practice.
Mhm.
I think that perhaps I could look if there are also questions right now from the audience. I'm sorry, we have monopolized the question and answer portion, but oh, okay, I'm reading right now, and there are some comments already. So people are saying comments about the novelty of it. Definitely a first for me. And they are also saying thank you for the very detailed, yes, the very detailed and fascinating presentation. And one a commenter said that, wow, amazing passion and empathy. So it really shows through how you have presented it and how this can actually help these clients with SMIs and shifting the focus from making it stressful, and maybe the way that we are approaching it can really help in for us to help our clients as well. Okay, if there are other
Thank you.
questions, please feel free to put them in the Q&A. I will be giving another minute for persons to type it in if you have burning questions, because this was a really interesting presentation from our speaker, from Dr. Sivan. Okay. Okay, I think that there are none so far.
Wow.
However, if you are able to think of another one by later, you can feel free to chat it and we'll direct it to Dr. Sivan as well. Thank you so
Thank
much
you
once
very much.
again. All right, so that was our first presentation by Dr. Sivan, and now we are moving on to our second presenter. So let me just introduce her. Okay, so we have with us our second presenter. This is Apin Chapat Kongkerd, who graduated with a Master of Sciences in Occupational Therapy. She has more than 23 years of experience in occupational therapy and assistive device services. Pat is a key person in implementing the WHO wheelchair service training packages in Thailand. She spent a huge amount of effort to enhance wheelchair service delivery as well as building capacities of healthcare personnel on wheelchair and assistive device provision. Currently, Pat has been involved in establishing an OT curriculum in bachelor degree level at Srinakarin Tharawirot University. She has published many research studies on rehabilitation and assistive device services. So she is going to be presenting today about the effectiveness of vision rehabilitation services on functional performance in daily living of persons with visual disabilities. Let us now welcome our speaker. We have our speaker now, Miss Apinchapat Kongkerd. Hello and welcome.
Hello, good afternoon, everyone. Can
Okay,
I share my screen?
yes, let me just make sure that you are pinned on the screen so everybody can see you. Here we go. All right.
Hello, everyone. Good afternoon. Today, I'm going to present you this study about effectiveness of vision rehabilitation on functional performance in daily living of person with visual disabilities. In Thailand, there are around 200,000 people registered as visual disabilities, which is around 10,000 of total number of persons with disability in Thailand. And according to the Person with Disability Empowerment Act, Thailand, people with disabilities can receive medical treatment, rehabilitation program, and assistive devices for free of charge. However, in the field of vision rehabilitation, currently there are only university hospital provide rehabilitation program and devices for people with visual impairments. And there is no study report on effectiveness of the vision rehabilitation services in Thailand. So since 2014, SNMRI, my workplace, has been providing the vision rehabilitation clinic. We established the services in order to increase accessibility for people with visual disabilities. And occupational therapists and public health officers were involved in the clinic. The objectives of this study, we would like to study changes in functional performance of persons with visual disabilities before and after receiving services from SNMRI, and to study user satisfaction on low vision aids. The services, including after people finish treatment program from ophthalmologists from other hospital, and they found that there no progression on the treatment, but they still have visual impairments, so they can come to the clinic for rehabilitation program. After the doctor prescribed the program, they will be assessed by our team in order to find their needs and activity of daily living and their environment. So there are 5 major activities that we do provide in the clinic, including vision screening, low vision aids provision, white canes for the blind, orientation and mobility training, O&M training for the blind, and activity of daily living training. And after that, we evaluate using ICF corset before and after the program. This study was a retrospective study. The data was collected from outpatient cards, from the outpatient cards 5 years. So since the clinic was started. So the data collection from ICF corset and follow-up form was collected. This is the ICF corset for persons with visual disabilities developed by the Ministry of Public Health in 2012. The Ministry of Public Health setting the team to develop the ICF corset to use in different types, different category of disabilities. And these 10 items were selected for people with visual disability. Results. From the study, we found that over 5 years, there were 421 people with visual disability access to the services, which not too many number around average around 100 per year, and number of male patients bigger than female. The age around between 25 to 34 years and 45 to 54 years. And the majority of them were employee, actually temporary employee, not permanent. And the around half of those have vision disability caused by retinitis pigmentosa. These are the visual acuity of the sample. People who come to the clinic, we found that the majority have very severe disability in the category of blindness. Most of them are blindness. About the service, we found that the majority relating to their impairments, the majority come to the service for the white canes, but they get training, orientation and mobility training to the blind only few, which means those people have get trained from other places and they come to us for devices. And those people receive low vision aids around 30% of them. And around 24% receive ADL training. When comparing ICF score before and after receiving service, we found that the data complete only people who receive ADL training with low vision aids. So when comparing for 10 items, we found that the majority of them, there are statistically significant difference in many items except using transportation and doing housework. The other 8 items, we found that there were big changes in those people after receiving the service. Regarding user satisfaction on low vision aids, we found that most of them very satisfied to the service. They found that the device meet their needs, and the advice from our staff can help them in doing activities. And overall, they're very satisfied to the device that we provide. So from the result, the majority of clients of the vision rehab clinic were people with blindness, as I showed. However, they receive orientation and mobility training from other services, but they come to get white cane. So, which mean that this clinic can increase the number of accessibility of those people to the devices. And the low vision aids, we found that the people who receive low vision aids have very much changes in their performance in their daily living. That means these things, that device is very important to those people. Even though they have no changes on using transportation and doing housework, I think this might be because the sample received low vision aids for reading. The majority of the low vision aids provided here, they are for reading. So they will not needed for transportation and housework. And some of them, they already get training, orientation and mobility training, so they can travel on their own, the same as before they come to us. So those activities not different, not change. I would like to conclude that occupational therapists could play important roles in providing ADL training to people with visual disabilities. If in Thailand, OT in visual impairments very rare. The not big group that work with people with visual disability, especially for adults who get visual impairments um, later on. In Thailand, many OT can work with children with visual impairments, not adult. So actually, there is a lot of needs of occupational therapists in those people who have visual impairments, and home modification might be considered for those people as part of OT roles. Actually, in the record, we found that home modification was mentioned in the service. However, there was no evaluation before and after. So the staff provide the service, but no data record. This might be one thing that our clinic have to develop and improve. Vision rehabilitation has positive outcome. Obviously, that's very good idea to promote this rehabilitation program to people with visual impairments, and especially accessibility to the rehab program for those people in Thailand must be promote more, because only big hospital have capacity to provide that. Because people say that providing visual rehabilitation spend much time for each person, but they have patients with eye problems. A lot of people come with the disease, and they have to take care of the majority of people. So only few people can have time to spend with people with disabilities. And of course, those services could provide positive impact on their quality of life. I think the next study should be study in other settings in Thailand as well, and also the OT roles in this field might need to be promoted in Thailand. Thank you so much.
Thank you very much to Pat. Yes, hello, and thank you for that presentation. We will now open the Q&A for this session. I believe we already have questions for you. So let me just show it on the stage. So here we have, I am wondering if they also help the clients return to their places of employment. And if they did, how did they go about it?
Thank you so much. This is one of our recommendation in the study, because from present study we didn't cover this point. That's a very good point that we also think about that. What's next?
Yes. I believe that, let me just check. Oh, I have somebody who's saying hi, Pat. All the best. I am looking for more questions from the audience. If you have any, kindly put them in the chat or in the Q&A so that we can field them for our speaker. Yes. And, it's wonderful that you have created this kind of study because, as one of our keynote speakers also mentioned earlier, that we need to build evidence base. And if you are saying that this is something that we need to lobby for in the government, the results of such a study can help push for that agenda as well. Okay, I'm still waiting for more questions. Okay, any other questions coming in from the audience?
I
Don't
don't think there's more unless, are you guys still typing your questions?
Possibly they may be typing. Oh, I believe there is a follow up from the previous question. I apologize. Or is that under economic self sufficiency? So it was about helping the clients return to their places of employment. Yes. Okay. I think that there are no other questions so far. So, again, if you have any that you would like to message to Pat, please feel free to let us know and we will direct it to our speaker. Thank you so much for your presentation once again. And we'll see you. All right. Thank you very much. Okay, so Diane, is there what do you call this? Is there
An
another
update.
presentation lined up for us?
Oh, wait, before we go on to that, I think there's a follow-up question.
Oh,
Okay,
okay.
I believe this is for the presentation that just finished earlier. Can I
Okay.
show it
All
on
right.
stage?
Yes.
Okay, it says here, what are possible provisions from national and local government that can help in establishing visual rehabilitation clinics? So if
Okay,
we
so
can,
if we could
are
ask
you still
Pat.
there, Pat?
Yes.
All right, we have a
It's
Yes.
a
new
follow-up
question for
question.
you.
What about the provision? Yeah, yeah. We try to um, push the policymaker to think about that. I work for a national rehab institute, and we try to negotiate with the policymaker, and we support with personnel training on the vision rehab. We develop many training course on that, but there are still some challenges, and we have to fight more.
That's true. We do have to advocate for these services to be available for our clients who need it. Thank you so much, Pat. So, last call for questions for our speaker. Okay. Okay. If there are none, thank you once again, Pat. Thank you so much. All right. So, we are now going to move on to our next presentation.
So for the last presentation, Dr. Toshiaki Sato is um he's still not here. Okay, we're still trying to contact him, but he has actually given us a recorded presentation. So while waiting for him, we're going to play that presentation for you. And if ever he comes in to answer your questions, then you may directly ask it in the Q&A box. If not, you can directly email Dr. Sato for your questions.
Okay. Just give me a few moments to be able to play that video.
So while Ding is preparing that, let me just briefly tell you of Dr. Toshiaki Sato's background. So,
Chairperson. My name is Koshi Matsuoka.
Oh, apologies.
I'm sorry, it's okay. You can pause it for a while. I'll just quickly introduce our speaker. So, Toshiaki Sato, OTR, PhD, is a professor in the Department of Occupational Therapy, Yamagata Prefectural University of Health Sciences, and the Graduate School of Health Sciences, Yamagata Prefectural University of Health Sciences, Yamagata, Japan. So today is going to present his study on the effects of blue light irradiation on sleep quality, post-wake attention performance, and work efficiency in health participants. Okay, so thank you, Dean. You may play the video now.
I am Toshiaki Sato in Japan. My research presentation is Effect of Blue Light Irradiation on Sleep Quality, Post-Wake Attention Performance, and Works Essentially in Healthy Participation. Introduction. In recent years, personal computers and smartphones has become widely used in modern society. However, they produce blue light and expose people of different ages to almost constant initiation. Such use of blue light device has raised concern as its use in influence sleep or sleep disturbance. Purpose. The evaluation of the sleep status of patient is crucial for occupational therapists. Therefore, in the present study, we aim to investigate the effect of blue light irradiation on sleep quality, post-wake attention performance, and work essentially in Hensley participations. Subject and method. 10 young Hensley men were enrolled in this study. Prior to the participation, the Pittsburgh Sleep Quality Index Japanese version was administered, which confirms the sleep score 5 or less. Subject and method. Assessment index 1. MAT sleep meter sleep scan 2. Sleep study system sleep tester 3. Psychomotor vigilance task monitor PVT 4. Work essentially Purdue pegboard test 5. Subjective sleep quality OSA sleep inventory 1. Sleep scan 2. Sleep tester. This slide shows 3. Psychomotor vigilance task monitor PVD 4. Work essentially Purdue pegboard 5. Subjective sleep quality OSA 5 factor. This slide shows in characteristic participation. Participation number 10, age, height, weight, BMI, Pittsburgh Sleep Quality Index Japanese version, mint 4.2. This slide showed in OSA sleep inventory. Blue light exposure did not significantly affect subjective sleep quality. This slide showed changes in vigilance task performance after light exposure. The difference in attention performance after incandescent blue light exposure was also not significantly associated with the total measurement time. However, the attention performance was significantly decreased in the last 5 minutes of the 10 minutes measurement period. This slide showed changes in result of working essentially caused by increased blue light exposure. Work essentially following blue light exposure was significantly lower than that after incandescent light exposure. Conclusion. Subjective sleep quality and sleepiness were less affected by increased blue light exposure. However, due to the increased amount of blue light initiated, attention decreased in the latter half of the 10 minutes measurement time. In addition, work essentially also decreases. This research suggests that changes in subjective sleep, feeling, and sleepiness may affect performance even if the individual is not aware of it. Thank you so much. Contact, email. Thank you.
Okay, so thank you very much. We are back. And unfortunately, as of now, we are still unable to see Dr. Sato in our audience. So, probably what we're going to be doing is that if you have questions, feel free to put them in right now in the Q&A, and we will be making sure to send them along his way. So, I'll give everybody a few minutes to kindly type in questions that we can provide to Professor or to Dr. Sato. We'll be emailing those to him. So if you would like to put in, please feel free. Okay, so let's give us 2 minutes for us to do that. All right, so we have a current question. Oh, this is a very good one from one of our audience. Is there a recommendation as to the number of hours before bedtime we should stop using gadgets? So that is definitely something that our speaker will be forwarding that question, and will be able to hopefully get that answer and share it with everyone here. Any other questions that would be interesting for you? We have somebody here who's saying what an interesting presentation, especially relevant now given our consistent exposure to gadgets and devices. How true, very true. But you can see here that there's good things about technology. There's not so good things. So in our previous presentations, technology was used to expand performance-based evaluation and to aid our clients with visual disabilities. However, in this case, we are seeing how technology can also have a negative effect on our own performance. Okay, so we are looking at all of these. We have to temper our use of technology nonetheless. All right, so are there any other questions that we would like to forward to our speaker? In case he is able to come in. And if not, we will just email this to him and hopefully get these responses back to our delegates. Okay. All right, I can see somebody chat. Oh, I am amazed at the various roles that us OTs can do. Definitely participating in sleep activity. I'm proud. How true. It's a very valuable occupation after all. Okay, we have another question coming in. Thank you very much for good questions. What is the validity of the use of blue light filters when using gadgets before bedtime? So this is something that we will be forwarding to Dr. Sato. Okay, and hopefully we'll be able to give back to you the answers to these questions. Okay, a last call for our questions. These have been very interesting. It can be for any of our speakers from today. We've had very, very interesting presentations, very good research that we would like to use in our own practice. Let's give a last minute for that. Okay. I am checking. Perhaps one is still typing. We just want to make sure to cover everything. Okay. All right. So thank you very much. I guess that would be it for our questions. Okay. Thank you to all of our speakers. And before we end, we would like to present certificates of appreciation for our speakers. We're currently experiencing technical difficulties, but as soon as we can get it sorted, we'll be able to show it on the screen. Let me just read it for you now. Okay, the certificate reads the Philippine Academy of Occupational Therapists and Learning Ablers present the certificate of appreciation to Dr. Sivan Regev for being an oral presenter during the 7th Asia Pacific Occupational Therapy Congress hosted by the Philippines via air meet on November 22nd, 2021. This is signed by Roland Lyle Duque and Arcel Rosario Gozon, our co-conveners, and by Dr. Anthony Gresha, our president of the Philippine Academy of Occupational Therapists. Thank you, Dr. Sivan. We are very grateful. And we would also like to present the certificate for another of our speakers. Okay, so can we kindly show that there we go. Okay, so we would like to present the certificate of appreciation for Apinchapat Kongkerd. Okay, for being an oral presenter during the 7th Asia Pacific Occupational Therapy Congress hosted by the Philippines via air meet on November 22nd, 2021. This is also signed by Roland Lyle Duque and Arcel Rosario Gozon, our co-conveners, and Dr. Anthony Gresha, our president of the Philippine Academy of Occupational Therapists. Thank you so much. All right. Thank you very much, everybody. And we hope
Thank
that
you.
we've been able to get lots of insights and we've been able to see interesting research being done with regards to this topic. So, again, thank you to our speakers. Thank you for joining us here. And to all the delegates, we are sure that you've learned so much from their presentations. Thank you. And we will now end the session. All right. Goodbye.